So today I'll be talking about principles of medication use in older people. I want to acknowledge our sponsors, the grant from the Administration for Community Living, Catholic Charities, Hale Kuike, and also our own Department of Geriatric Medicine's Pacific Islands Geriatric Education Center. So these are today's learning objectives. I'm going to be covering key issues in geriatric pharmacology. I'll talk about the effects of age on both pharmacodynamics and pharmacokinetics. And of course, I will explain what these terms mean as well. I'll talk a little bit more about risk factors for adverse drug events, and then also talk a little bit about drug-drug and drug-disease interactions, and then end with good principles of prescribing for older people. I'm going to start out with the epidemiology of aging. We all know that the population of the whole world is aging, and particularly of the United States. Currently, it's over 45 million people who are age 65 and older, and actually it's closer now to 16% of the population that's over the age of 65. I think most of you know that Hawaii has the longest life expectancy in the United States. And so in Hawaii, this is even more of an issue than in other places. Now, although the aging population is only about 15 to 16%, they use a disproportionate percentage of medications. So over 33% of prescription drugs, over 1/3 of all prescription drugs taken are taken by this population. If we look at, in general, the elderly population, over 90% of older people take at least one prescription drug. And polypharmacy, or taking multiple medications, is extremely common in older age. So I'm going to share this graph. So on this axis here, we see age in years. And this y-axis is the percentage of people taking medications. And these bars on the left represent young people, 0 to 11 years of age, then 12 to 19, and then 20 to 59. And then this last group of bars is people who are 60 years of age and older. And if you look at these colors here, blue is 1 drug, then the darker green is 2, the lighter blue is 3 to 4, and the lighter green is 5 or more drugs. So I want to focus on polypharmacy, 5 or more medications. As you can see, in young ages, almost nobody is taking 5 or more medications. It gets a little bit more common, but still it's only 8% in those who are 20 to 59 years of age. Now look what happens when we go to the people over the age of 60. It's 36.7% of people are taking 5 or more medications. So you can see that certainly age is a big factor in people taking more medications. So why is this? Well, first of all, older people are more likely to have multiple illnesses. And we know that if you have multiple things going on with you, you may be put on multiple medications for those illnesses. The other thing that we see that's common with aging is older people often will see multiple doctors. And unfortunately, we don't always have good communication between the doctors. So it's common that I've actually seen this, where somebody is actually on the same medication given by 2 different doctors, and they're taking double the dose because maybe it's with a different name. So they don't realize it's the same medication. So you can imagine, right? Somebody goes to their cardiologist and they just happen to mention, oh, my shoulder hurts. And the cardiologist, well-meaning, gives them something for the shoulder pain, but they're already being treated for that by somebody else. So often the lack of communication can lead to multiple medications being taken, sometimes with dangerous side effects. I always say we need to have a captain of the ship, and that should be the primary care physician. So even if you're seeing multiple specialists, I strongly recommend that all medications go through the primary care physician who knows what's being given by all the specialists. Over-the-counter medications are a big issue as well. Now, people assume that because they're over-the-counter, they must be safe. And for the most part, that is true. But even over-the-counter medications can have major side effects and have drug interactions with your prescription medications. So it's very important, again, that people be aware, and even your doctor be aware, your primary care doctor be aware of all the over-the-counter medications you can take. One of the things that we see with Alzheimer's disease is that people who have dementia, particularly Alzheimer's, have an imbalance in the neurochemicals in their brain. One of those neurochemicals is a chemical called acetylcholine, which is much lower in people with Alzheimer's disease. Some of these over-the-counter medications, things like Benadryl, even other over-the-counter medications, can have anticholinergic effects. So actually, what they're doing then is in somebody who already has a deficiency of acetylcholine, now giving this medication makes that deficiency much worse. So something like Benadryl, which can just make you and me sleepy, will have a very paradoxical effect on people with Alzheimer's and make them very agitated and upset. And so people get puzzled about that. It's supposed to make them sleep, and it's actually making things worse. Well, that's because of not knowing that this can have a problem with Alzheimer's. Shared medications are unfortunately a problem too. So this is, again, very well-meaning. Somebody tells their neighbor, oh, I'm having a lot of trouble sleeping. And the neighbor says, here, why don't you share my sleeping medication that was given to me by my doctor? Not a good idea. Nutraceuticals, herbal medications, again, those are very common. In fact, I think a few years ago, somebody did a study that showed that Americans spend more on nutraceuticals or herbal medications than they do on prescription medications. So we know it's a very common issue. These medications are not regulated by the FDA. And so often they can have side effects. Some of them are not even effective at all. And they can add to the polypharmacy issue because people can take a lot of these medications. So the consequences of polypharmacy, unfortunately, can be quite bad. The more medications you take, the more drug interactions you'll have and the more side effects you'll have. So obviously, that's something that we don't want. In older age, we see an increased risk of what we call geriatric syndromes, cognitive or memory problems. Some medications can make patients extremely confused. Falls and injuries. Again, some of these can be linked to use of medications as well. Urinary incontinence. In fact, if I see somebody who has a new onset of urinary incontinence that just came on, the first thing I ask is, was a new medication started around that time? And often we'll find that that's the reason why somebody's having the new onset of incontinence. Sometimes it can be more subtle. It can be just a sort of gradual decline in function. So somebody's declining slowly and nobody knows exactly what's happening. Nobody times it to a particular medication. But then you see a geriatrician and they look at the whole list and they say, let's cut out some of these medications. And suddenly the patient gets much better when some of these medications are removed. Another issue at all ages is compliance. Are people going to take the medications the way they're prescribed? Now, this is an issue at all ages, but actually, surprisingly, older people are more compliant than younger people. In general, older people take their medications as prescribed better than younger people do. I guess that's one of the advantages of old age, right? Hopefully, we gain some wisdom as we grow older. Poor compliance is also associated with more complicated regimens. For example, if you're given a medication that needs to be taken 4 times a day, I know I certainly will not do very well with that, right? So the simpler, the better to get people to actually take the medications as instructed. Cost can be a huge issue. Some older people have very good medication coverage with their health insurance, and some don't. And sometimes, with an older person on a fixed income, the question is, do I buy medication or do I buy food? Well, most people will choose to buy food instead. So again, that's something doctors are not good at. We're not very good at knowing costs of medications. I know I'm not good at that. I always encourage my patients to come and tell me if the medication's costing too much, please tell me so I can look for cheaper alternatives for you. Some conditions are asymptomatic. And so people think, well, I'm not having any problems, so why should I take the medication? The most common example for that, I could say, is probably high blood pressure. Most people who have high blood pressure have absolutely no symptoms. They don't even know they have it until the blood pressure is measured, and then you're told you have high blood pressure and you're given advice about what to do with diet and exercise, and sometimes with medications being needed. So you take the medication for something you have no symptoms for, and the medications don't make you feel better. Sometimes they make you feel worse. So you figure, why should I take it? Well, the reason to take medications for high blood pressure is not for now. It's because having high blood pressure over 10, 20, 30 years can cause complications. What you're doing is you're taking medications to prevent those long-term complications. Again, good education is key for that. This was a study that was done looking at medication compliance. So if you look at this green bar here, this is 100% of medications that are prescribed to people. Then this yellow bar is the percent that was actually filled. So you get the prescription from the doctor and you actually go to the pharmacy and fill the prescription. And you see 12% of prescriptions are never even filled. So you take it home, but you don't fill the prescription. So now we're down to 88%. The next, the orange, is the actual treatment taken. Again, 12% who filled that prescription will not take that medication. So now we're down to 76%. Now we go to this last one, the pink. This is continuing the treatment as the physician wants you to. Here we see a bigger drop-off. 29% won't continue taking that treatment. So now you see, by the time you end all of these, less than half of people are taking medications as they should be taking them. Let's move on to some age-related specific problems. One is poor vision. I don't know about you, but you look at those tiny little medication bottles you get, sometimes it's very hard to read the label. So if you have poor vision, you can imagine that somebody cannot really read those instructions well. So pharmacies can give you large font labels, but you have to ask for them specifically. Poor hearing, I think, is even more important. The physician often at the end of the visit will tell people, right? These are the medications I want you to take, and this is why I want you to take them. Now, particularly here in Hawaii, we have a very polite older population. So when they're listening to the doctor, they're smiling and they're nodding, but they're not necessarily hearing everything. So I always ask, at the end of my instructions, I always ask, now you tell me what you think I said, because then I can be sure that they actually heard what I said. And if they didn't hear, that means I didn't do a good job and I need to explain again. Memory problems. Can they remember what you said? They might hear very well, they might be able to read the label, but they don't remember anything. That can be a real problem. And if that's the case, then maybe somebody needs to supervise their medications. Arthritis. Can you open the bottle? Many of these bottles have child-proof caps. I know when my daughter was little, she could get into those bottles very easily, but often older people with arthritis can struggle because they have problems with their wrist or their fingers. Swallowing problems. Some pills are huge horse pills, very hard to swallow. So again, you need to ask about those. Some of the vitamins can be huge. Calcium pills can be huge and often can cause problems with swallowing. So next I want to talk about this medical student Tic-Tac exercise that we do. So before I start that, I just want to say the John A. Burns School of Medicine is very unusual. It's one of the very few medical schools in the United States where all fourth-year medical students, before they graduate, no matter what specialty they're going into, they have to come through 4 weeks of geriatrics and palliative care with us. And so one of the things we try and teach them is some sensitivity towards medication issues with older people. So one of our faculty devised this really cool Tic-Tac exercise. So we have 4 different colored Tic-Tacs, green, white, blue, and orange. And we actually give medication bottles. So one of the pharmacies was very kind. They donated these medication bottles and they made the labels for us just so that we could use them for this particular exercise. And it gives instructions about how to take them, whether to take them with food or without food, how many to take, how many times a day to take them. And we fill these bottles and we give them to the medical students and we tell them take it for 1 week and then bring back the bottles next week. And if they took the medications as they should, all the bottles should be empty when they come back next week. Well, guess what? They're not. They didn't really take those medications well, like they should have. So it gives them some sensitivity, like if you're asked to take a medication multiple times a day, wow, that was really hard for me to do it. And they come back with stories about, yeah, I realized that I didn't take my lunchtime medication, so I have to decide, do I take 2 at dinner time now, or do I just not take it? They see the things that patients are actually faced with. Let me move then into pharmacodynamics. This is what the drug does to the body. The effect that the drug has on the body is called pharmacodynamics. At the same concentration of medications, older people are more sensitive to the effects of medications. So the same drug level and the older person will have side effects, a younger person may not. One of the major side effects we see is in the brain. And we do see some changes in the brain with aging. We see that even with normal aging, there's a decrease in neurotransmitters. These are the chemicals that send messages between brain cells. One of those is acetylcholine, the memory chemical, the one I was telling you about previously. So even with normal aging, this is lower. Of course, when somebody has Alzheimer's, Parkinson's, other neurological problems, that deficiency becomes even worse. There's something called the blood-brain barrier. This makes sure that when you have medications in your bloodstream, it doesn't all go into your brain and cause problems and side effects. So there's a barrier, so it keeps some of those medications out of your brain. Well, in older age, again, even with normal aging, this blood-brain barrier isn't as good as in younger ages. So more of the medication is going to go to the brain and again cause confusion or side effects. This is even more true with somebody who has Alzheimer's disease. This blood-brain barrier is even worse with anyone with a neurological condition. And we know that neurological conditions, unfortunately, are more common with aging as well. Next, I'll go into pharmacokinetics. So this is what the body does to the drug. Once the drug gets into the body, what happens to it? So these are the 5 major categories. First thing is absorption. It needs to get into your body, needs to get into your bloodstream. The next is volume of distribution. Once it's in the body, how does it get distributed all through the body? Protein binding. Most drugs are bound by certain proteins in the blood. Then metabolism. This is breaking down the medication into different forms. And finally, excretion, getting rid of it from your body. I'll go through each one of these separately. So starting with absorption, bioavailability, which is basically the amount of drug that is absorbed, is usually unchanged. However, with Many drugs, particularly those taken by mouth, which is most medications, bioavailability or absorption may be delayed with older age. There are many things that can happen to your gastrointestinal tract. One is absorption is very much dependent on what else is taken with the drug, whether it's food, whether it's things like milk, even other medications. What is the pH or acidity level in your stomach? How about motility? Is your gastrointestinal tract moving well, or is it slowed? Or GI illness? Now, some medications can slow the GI tract itself. So basically, when you take that medication, your GI tract is working, but it's not working as quickly as it would. So you can imagine the next time you take that medication, the absorption will be slowed, right? So again, you can see that it can slow its own absorption for the next dose and the next dose and the next dose. Sometimes I have people come and tell me, oh, let's say they're taking something in the evening or at bedtime, maybe that helps them sleep. And they come back and they say, you know, I took the medication and I lay in bed for 2 or 3 hours and then it didn't fall asleep for a couple of hours. So often what doctors will do is they'll increase the dose of the medication. I usually, instead of increasing the dose, what I do is maybe I move it a little earlier, because it could be that it's just an absorption problem. So taking it 2 hours before bedtime might be better than taking it at bedtime, because it'll have time to have its effect. Much better than raising the dose. Intravenous medications, of course, there's no difference with age. They get into your bloodstream as quickly as they do with young age. But intramuscular medications, so shots into your muscles, the absorption may actually be quite erratic. And we can see highs and lows that we can't predict very well. This is because with older age, we see decrease in muscle mass and decrease in muscle blood flow. So you see this erratic absorption. Now, some things have to be taken intramuscularly, like your flu shot, for example. So some things you have no choice but to take it through your muscle, even though it may have erratic absorption. However, certain medications, long-acting depot medications, I usually don't recommend in older people. I think it's better not to use those because of this erratic absorption with highs and lows that you can't really control. Don't forget the skin and the eye. The skin with aging is definitely thinner and has more breaks in the skin. So certain ointments that you might take, you might think it's only having an effect on that area where you're putting it, which is like a rash or something like that. But we do see with older people, a significant amount of that could get absorbed into your bloodstream. So certain ointments like steroid ointments, you could have effects on your whole body, not just on the part of the skin you're putting it in. Same with eye drops. Certain eye drops for glaucoma, for example, can get absorbed through the eye and can actually cause confusion or other side effects like that because it's going now through the entire body. Next is something which we call volume of distribution. So once the drug is absorbed, what happens to it? It's distributed all through the body. Well, one thing we notice with old age is that body weight decreases after the age of 65. So when I first heard this, I was going, yay, isn't that wonderful? I can look forward to losing weight when I get older. But actually, that's not a good thing. The weight loss is not because of good reasons. It's because lean body mass is being lost. We're losing muscle, bone, and water. We're not actually losing fat. The percent of body fat is actually going up as we age. So with this increase in total body fat, now we have this higher pool of fat waiting. So for medications that were what we call lipid soluble, they're absorbed by the fat. Now we have this bigger fat pool that's waiting to trap those medications and hold on to them. And then they release it slowly. So what we see is a longer duration of action of these medications. They stay in your body a whole lot longer. And most medications are actually lipid soluble, most medications. So that means they're acting longer in your body than they would at younger ages. We also see a decrease in total body water, unfortunately. So now for water-soluble drugs, now we see that the bucket is half empty. So you throw the same amount of drug into that bucket, and of course, the concentration is going to be much higher. So we see higher peaks and toxicity of water-soluble drugs. One of those is alcohol. Alcohol is water-soluble, and that's why we see that people who were able to take a certain amount of alcohol in younger ages, now as they get older, they can't tolerate the same amount of alcohol because that bucket is now half empty and you see higher peaks. Protein binding. There are many proteins in the blood that bind to different types of drugs, and often in old age, particularly with people who have malnutrition, we see a decrease in this protein level. So there's a higher percentage of unbound drug, and this is the part of the drug that's actually active. I want to really stress this. Even my students often don't know this. Blood drug levels can be very misleading because they usually measure total level of the drug, not the active or unbound drug. So I always tell my patients and my students as well, don't treat the number, treat the patient. It's very possible to have toxic effects even with what we call normal drug levels. So always look at the patient and what side effects they're having and what other problems they're having. Don't just say, well, the number is normal, so I'm not going to worry about it. Metabolism is defined as chemical changes in the drug to basically get ready to get the drug out of your body. And most commonly, this is done in the liver. Now, with normal aging, even in the absence of liver disease, there is a slight decrease in liver blood flow, size, and function. So some drugs will take longer to metabolize. Again, you see the theme, right? It's hanging around in your body longer because it's not able to, the body is not able to get rid of it. Certain other comorbid conditions like congestive heart failure can also affect your liver function. And so even though you may not have liver disease, having congestive heart failure might make your liver not work as well. So the metabolism again can be slowed. Excretion, or getting rid of the drug from the body, is most commonly done by the kidney. And we see that kidney diseases are more common with age. And even in the absence of kidney disease, aging causes a decrease in kidney size, blood flow, and function. So many older people, even with no kidney disease, can have some decline in the ability to excrete medications. This can lead to drugs accumulating in the body and having more toxicity. I want to talk a little bit about this term called half-life. Half-life is defined as the time for a drug concentration to decrease by 50%. So I'll talk a little bit more about that in this next slide. Here, on this x-axis down here, the horizontal axis, I've got time in half-lives. So you can see this is 1, 2, 3, 4, 5, and 6 half-lives that are measured. And here we're having the percent of the drug. So we start out at 100% of the drug over here. And by the first half-life, you can see half of that is gone. So now we're down to 50% of the drug. By the second half-life, half more is gone. So now we're down to 25. Then we're down to 12.5. You get the idea, right? So each time with each half-life, we're down 50% of the previous level. The example I want to use is Valium or diazepam, which is a very commonly used tranquilizer or sometimes used for sleep. It's used for anxiety, for sleep, for lots of different things. In a young adult, the half-life of this medication is about 24 hours. So it's a long-acting medication. It's something that hangs around in your body, even in young people, quite a long time. In older adults, though, the half-life is 4 times as long. It's almost 100 hours. Now, what does this mean? That's 4 days. It takes about 5 half-lives to say that there's very little drug left in your body. Your body got rid of most of it. You see down here, right? Now you're down to less than 5% of the medication. So if we multiply 4 days, which is this half-life, times 5, that's 20 days. 3 weeks, this drug is going to be in your system if you took it. So even if you stop taking it today, the effect is going to be hanging around for a very long time, which is why in general, I don't like long-acting medications in my older patients, because I know that once it's in there, there's nothing I can do to take it out. We just need to wait for time. The opposite is also true. So I told you how the medication hangs around in your body longer with older age. But reaching what we call steady state is also true. So let's say you start taking a new medication. The red is younger people. So you take your dose, your level goes up, then it goes down again. You take the next dose and it goes up. And then finally you reach what we call steady state, where it wavers between this level, between doses. You can see with older people in green, you can see that it takes longer to reach steady state. So the opposite is also true. Don't give up too soon on a medication, because you may not see some effects, but you may have to have patience and wait to see the effects of the medication. So then what is successful drug therapy? You need to hit that bullseye every time. It's the right drug at the right dose for the right condition and the right patient, and failure in any of these can lead to what we call ADE, or adverse drug events. Unfortunately, this is a very common issue. Adverse drug events are responsible for 700,000 ER visits every year in the US and 120,000 hospitalizations each year. So very common problem. Also very expensive problem. We spend billions of dollars each year dealing with the effects of these adverse drug events. And the sad thing is that many of these are preventable. So instead of having all this pain and suffering and financial loss, wouldn't it be better to try and prevent it instead? Older people in particular are very prone to these adverse drug events. We want to be very careful with them. They're also the least likely to be able to tolerate adverse drug events because they have more frailty. So all the more reason, again, to be more careful with older people. These are some of the risk factors. The first one is advanced age. The next one is taking more medications. This could be prescription or even non-prescription, over-the-counter, or even herbal medications. But the more you take, the more likely you are to have adverse drug events. Having a prior adverse drug event, particularly with that class of medications, something to be very careful about. Use of alcohol is a risk factor. Low body weight is a risk factor as well. And many of our older Asian patients here are very thin. That's their baseline. You know, I have patients who 90 pounds is their baseline weight. Of course, they are more likely to have adverse drug events as well. And of course, poor liver or kidney function. We talked about how liver affects metabolism and kidney affects excretion. If they have those problems, more likely to have adverse drug events as well. The one I don't list here is dementia, but I've talked about that as well. People who have dementia, particularly Alzheimer's disease, they're more likely to have the brain side effects of these medications. This is a very unfortunate thing that I see quite frequently. We see this adverse drug event prescribing cascade. Somebody starts a new medication and they get an adverse drug event. And unfortunately, this is misinterpreted as a new medical condition. So what happens? Another drug is added, another drug effect, again misinterpreted, and a third drug is added. You can see how it's very easy to just keep adding and adding and adding. You get into this vicious cycle, you just get more and more medications added on. One thing I would suggest is maybe if you have an adverse drug event with a medication, instead of adding a new drug, maybe cut back on that first drug and see what happens. That's what I usually recommend to doctors is, especially if it's time, you can tell you started a new medication and the adverse effects started soon after that. Try pulling back a little bit and see what happens. Most of the time you can do that very safely. Drug-drug interactions between two or more drugs are very common. And again, the more medications you take, the more likely that this is going to be happening. Medications can affect the absorption or metabolism of other drugs. They can even exaggerate or diminish the effects of other drugs. So sometimes when you're taking two medications at the same time, it can negate the effect of one drug or can exaggerate the effect of the drug. And be careful of those herbal and over-the-counter medications. A few years ago, the anesthetists discovered this, that they were having these really bad reactions to general anesthesia. And fortunately, somebody did a study and discovered it was certain herbal medications that people were taking that were causing these interactions with the local or the general anesthesia medications. So now the general anesthesia, before you go through general anesthesia, they'll ask you specifically about whether you're taking herbal medications. But again, it makes it so, it really stresses why it's so important that your doctors know everything that you're taking. They have these wonderful computer programs now. It's impossible for any human to remember all the drug-drug interactions that are available out there. So when I'm not sure, I actually call my friendly pharmacist. If I'm adding in a new medication and somebody's already on a couple, I usually will ask them, can you just run this through your computer program, please, to make sure that it doesn't cause any interactions. Drug-disease interactions can be seen as well. People who have obesity, they have more fat, and that can alter the volume of distribution. Dementia can increase sensitivity or induce paradoxical reactions to certain medications, like I told you, the anticholinergic medications. Liver disease can impair detoxification of medications, and kidney disease can impair excretion. I want to talk about the Beers criteria. Now, people wonder what I'm talking about. This has nothing to do with alcohol, by the way. This was somebody named Dr. Beers who came up with these criteria and originally published them in 1991. And it's a list of potentially inappropriate medications that are best avoided for older people. Studies have looked at these medications and found that the risk is greater than the benefit for most patients. I really want to stress, though, for most patients, there are times when your doctor has to make a judgment. One example I'll give you, there's a seizure medication that it's one of the older seizure medications, and we don't use that very much anymore because there are much safer medications. The newer anti-seizure medications are much safer. I remember having this patient who the only medication that worked for his seizures was the older one that had more side effects. So again, the neurologist and I discussed this many times and then finally decided, even though it's a higher risk medication, it's the only thing that works on this guy, unfortunately through trial and error. So I won't say you can never use them, but you should think 2, 3, 4, 5, and more times before using some of these medications. This Beers criteria list has been updated multiple times. And since 2011, actually, the American Geriatric Society decided it was so important that they undertook that they would update these on a 3-year cycle. So they were updated. The most recent one was in 2019 that these criteria were updated. And now it's quite a massive list. So even I don't remember them all, so I often have to look that up to see whether something's on a Beers list. With electronic medical records now, The good thing is that the computer can tag it. So the computer can tag these medications, and if the person is over the age of 65, kind of flash a reminder to the physician to say, hey, this is on the BS criteria list of medications to be avoided. Are you sure you want to use it? So again, it's not telling the physician you can't use it, but it's making them think twice about checking to see whether they should use something else perhaps. The intention was for use in adults over the age of 65 in all settings: outpatient, hospital, long-term care, all settings except for hospice and palliative care. They made that an exception because in hospice patients and even at palliative care patients towards the end of life, our goal is really comfort. And so even if something has a higher risk, if it's going to make the patient more comfortable, that's what we've promised the patient and the family with hospice care. So that was one of the exceptions. The intent was to improve the medication selection process for older patients, to educate both clinicians and patients, with the ultimate goal being to reduce adverse drug events and improve quality of care, cost of care, and patterns of drug use in older people. Since then, other studies have also been done, and this group came up with, they thought the beers was not enough, so they came up with this thing called the STOPP-START Criteria, originally published in 2008 and then updated after that. And what they said is they agreed with the beers criteria that there were potentially inappropriate medications that should not be used. But in addition, they said there are potential prescribing omissions. So what they're saying is some medications are overused in older people and should not be used because of their risk profile. But on the other hand, some medications are underutilized, and that should be looked at as well. They demonstrated that this can improve medication appropriateness in the hospital and after discharge, and can reduce these adverse drug events and also decrease length of stay in the hospital. We want people to get out of the hospital as quickly as possible. We know that's a bad place for older patients. So using these STOPP-START criteria helped that. I want to just go, so some of these medications that are often missed in older people, that are underutilized, one of them is definitely vaccinations. We want to make sure that older people take the vaccinations that we recommend. The flu shot, for example, that's a big one. You know, some older people don't take that, and we know that it's been quite effective at not stopping the flu completely, but decreasing complications of getting the flu. Another category that's underutilized is possibly antidepressant medications, partly because older people's depression is not recognized as well because they may present atypically. And it may be partly because the physicians maybe are not comfortable prescribing the medication. But again, for somebody who has a major depression, antidepressants can really improve quality of life. So these are certain rules for drug use in the elderly. Start low and go slow. I usually start at maybe a quarter to 1/3 of the recommended dose in older people. Remember, I can always go up on the medication. It's very hard to take it away once it's inside the body. Keep assessing risk and assessment and benefit, always. Always balance the two, right? What's the risk? What's the benefit? The benefit needs to be greater than the risk. Don't quit too soon. You may have to be patient to see the effects of these medications. Monitor closely for side effects. In general, I avoid starting 2 drugs at the same time because then I'm not sure which one is causing the side effect. Obviously, there are exceptions to that. If somebody's very ill in the hospital, we're often starting multiple medications at the same time because it can be life-saving. But in general, for somebody who's stable and in the outpatient setting, I try not to do both. I do it one at a time. And then this last one is actually my own rule, my roller coaster rule. Now, Those of you who know me know my whole family, we are major roller coaster fanatics. My husband and I have always been, and my daughter now is as well. And I like the kind like this one, you know, the twisty kind that fling me around all over the place. But many years ago, my husband and I made this decision that in the first year that a roller coaster comes out, a new roller coaster, we won't go on it because that's when usually most of the problems happen. So we're going to wait until it's been tested for a while and then go on. And we've broken that rule, I got to confess. We've been tempted and we have broken that rule sometimes. But I follow the same rule for my older patients. In general, if a new medication comes out, say for high blood pressure, for diabetes, for emphysema, for whatever, I don't start it right away on my older patient because I want to wait and see what's happening with that drug. Remember, when a drug is approved by the FDA, often it's just a few thousand people that have been tested to get the approval. And sometimes you have to wait a little bit longer to see if more side effects are going to come up. Have I made exceptions to that? Absolutely. When the first Alzheimer's disease drug came out, of course, I wanted to try it in my older patients because it was the only option that we had. And there are other exceptions to that as well. But in general, I try not to try new drugs until they've been well tested. So we always have to ask ourselves these questions. Is the medication necessary? What are the goals and endpoints? Is the goal cure? Is the goal quality of life? What is it? Do the benefits outweigh the risks? Are you treating the effects of another drug? In general, I recommend not doing that. I recommend cutting back on that first drug. Could one drug be used for two conditions? And always be looking for those drug or disease interactions. So these are some good habits for doctors. We need to know, does your patient know what each drug is for? How do you take it? What are the possible side effects? Not only tell them, but maybe give written instructions as well. Simplify the medication regimen using something called a Mediset. You probably have seen this. We have Monday to Saturday here, and we have breakfast, lunch, dinner, bedtime, 4 little slots here for each day. So somebody can come and fill this for the patient so they don't have to do it themselves. They could come and do it once a week. One caveat, if the person has memory problems and they don't know what day of the week it is or what time of day it is, this is not going to work. So somebody who has dementia may need to have direct supervision instead. Avoid certain high-risk medications. And then my very sophisticated brown bag method. At each visit, take your medicines to the doctor so that they can actually look for what you're taking. Over-the-counters, herbals, vitamins, eye drops, ointments, everything should be included so that your doctor knows all that you're taking. Home visits are super useful for this. I've gone into people's homes and I've found things that are really scary. I've found old medications from 20 years ago that they're storing in the fridge just in case. I always ask, well, what are you going to do with this? And they say, well, I might need it someday. And obviously it could be very dangerous. And with their permission, I will get rid of that for them. So in summary then, successful prescribing means selecting the right drug at the right dose for the right condition, taking into account the individual patient and their own goals of care. So the other day I was in the hospital and I overheard 2 doctors talking. The first one said, what exactly does a geriatrics consultant do? And the second one said, not much. They just stop half the medications and cut the doses of the rest. The first one said anybody could do that. And the second one goes, the trick is figuring out which half.